Do what?
It's free.
It is free. It is a free medicine. Movement is medicine. It's a free medicine. I like that. I'm gonna have to steal that. Whoever. I'll trademark it for you. All right. So.
That's true, because sometimes it's hard.
So again, I'm Dr. Trevor Ling. I'm with Peak Potential Physiotherapy and Wellness. So we are a private practice here in the Memphis area. My wife and I started it 10 years ago. We actually have a place over here off of Oak Haven and then another place in Collierville. So we've been out in Collierville 10 years. We opened up here about a year and a half. So we are going to talk about physical therapy for the family medicine physician, which that is what y'all are, right? I'm not in the wrong place. But so movement is medicine. Thank you all for participating. Thank you all for staying and sticking with me for the last lecture. Hopefully I'll get through it and y'all can get on and all. Do y'all have to study anymore, or y'all?
Yes.
Oh, okay. Study what you see in the clinic every day, I guess, right? And residency, so y'all are basically done after this, right?
We're
Some
med
med
students.
Oh, med students, okay.
And residents.
And residents. Okay, well good. So we get some, this won't be on the boards, don't worry, okay? Okay, so I do want this to be a dialogue, not a monologue, all right? So if you don't know about physical therapy, ask me. If you don't know about certain aspects of physical therapy, ask me. That's the whole point of this, okay? So, because it is a lecture, well guess what? You always have to have objectives for your lecture. So we're going to go through these, see if it actually works. Okay. So we're going to review the common conditions referred to PT from family medicine, understand the process and the goals of a PT evaluation or physical therapy evaluation, learn how functional and restorative exercise and manual therapy are components of our integrative philosophy to PT. So I will juxtapose that in a little bit and what that actually means, or you can, the first person can ask a question and actually want to know what that means. What manual physical therapy and evidence-based modalities are available, and then to clarify the difference between PT, OT or occupational therapy, chiropractic treatment, and personal training. Okay? So I'm presenting to you how I believe the PT industry was created to work, based on the evidence and research. However, after doing this for 20 years and 16 years, 18 years in private practice, I do need to tell you that not all physical therapy is created equal, okay? I'm sure y'all have become physicians, you want to become physicians, y'all have had good experiences and bad experiences. You probably remember that one doc, like, oh, I loved going to that one. I might not want to go back to that one, right? Every industry is like that, okay? But I'm going to give you from my point of view what physical therapy, what the landscape should be based on the evidence and the research. So, show of hands, who's been through physical therapy? Right, okay? So we're going to go through some common things for physical therapy, but y'all all have, when you said physical therapy, or you saw a physical therapist, you're like, oh, well, this is what my expectations are from that. This is what I had happen to me. Okay, so hopefully I can either tell you, hey, you had some great PT, or hey, you might want to get some help with that too. But as a primary care physician, if y'all are going into primary care, y'all are in a great position. Okay, hopefully y'all are the quarterback. Y'all get to dictate the plan for your patient. So you get to help the patient out a lot. You get some immediate relief, hopefully giving them some sort of medication to help turn down the fire, as I like to say, or give them, it could be a prescription, a Band-Aid, something like that. But what if you could give them a tool that could also help them for the long term and not just put a Band-Aid on it, okay? You get to help them immediately, but what if you could help them for the long term, right? Would that be valuable for you? Mm-hmm. Right? Okay, so if you can help them for the long term, if you're treating their symptoms, what would be a long-term kind of treatment effect for that? There's different, what are y'all studying? You're studying different systems, right? So we don't want to just treat the symptoms, we want to treat the system in order to get to the root cause of the problem. I was about to say injury, but y'all deal with all types of things. So that's the premise behind this, okay? So what we deal with as physical therapists or in physical therapy is the musculoskeletal system. What I believe that entails, and y'all can tell me if I'm wrong, especially y'all who are studying it right now, but so I tell someone we can deal with muscle, joint, nerve, discs, all the things within that system. If you think about it, I tell people I'm probably the mechanical engineer who didn't like math, and that's why I went into physical therapy, because I didn't have to do as much math, right? I did have to do some, not as much as engineering. But think about the mechanical, the things that make you move, and what makes the mechanical move? The electrical system, neurological system. And that's what we're working on as physical therapists, okay? So that's us boiled down in a nutshell. But not everyone who has a musculoskeletal issue, and this is where y'all come in as primary care physicians. So y'all come in and someone comes in with, we'll get into specific diagnoses here, but someone comes in with pain or musculoskeletal injury, you get to rule out if something more sinister is going on, right? You have your red flags, your yellow flags. If you have a radiograph at your disposal, you can give them an x-ray, and then you give them something to calm things down. Hopefully it's an NSAIDs, pain medication, whatever it may be to calm things down, calm the fire down, but where are those coals lying around, okay? And that's where I'm talking about the system that we have to deal with, okay? So not everything that's a musculoskeletal injury needs to be sent off to orthopedics, okay? You've ruled out there's not a fracture, you know the mechanism of injury, you've ruled out a more sinister problem. Hey, they haven't had a large weight loss. Hey, they haven't gone through, it's not unrelenting pain. I can't change it. So I rule out kind of more of a oncology or something along those lines that could be causing pain. So why don't you quarterback that a little bit more? And that's where we can be a good adjunct or an ancillary service to you that I don't believe y'all might think about right off. So hopefully I can at least be that second thought process for you, or the next step once you turn down the fire, okay? And I'll tell you why here in a little bit, all right? All right, so that's what we're gonna go over. Now, some of the most common reasons to refer to physical therapy. All of y'all know these things, but you got lower back pain. I'm guessing at least 80% of the people who raise their hand probably have lower back pain, and that's why you, all right? So it also is under-referred, and we can discuss that in a little bit. I'll go through these one by one. Neck pain and postural issues. Well, y'all are in the generation, you grew up with these things in your hands, and don't get scared if you have your head forward, 30 pounds of pressure, all the TikTok videos and all that is not gonna blow out your disc or anything like that. Now again, movement is medicine, but when people always ask me, well, what's the best posture? I'm at my computer all day, I need to do this, I need to do that. Well, the best posture is the next posture. So keep moving. There's a reason OSHA standards are get up every hour. Every about 45 minutes you're supposed to get up and move. The whole point of standing desks, the whole point of workstations that you're standing at. If y'all are in the hospitals, y'all still call them cows? The computer on wheels. Okay. Wows.
Because you can't call it a cow, it has to be
Oh.
called a wow.
It's a workstation.
Workstation on wheels. The computers were a little bit offended. So we got neck pain and postural syndrome, shoulder impingement, rotator cuff pathology, bursitis, all these things that that you've studied here. Knee pain, OA, patellofemoral, pelvic health and incontinence, balance and falls and vestibular dysfunction, headaches, again under-referred, and neuropathy, again under-referred. Because my guess is, who here has had a patient with neuropathy? Do you know where to go with that?
Gabapentin.
Gabapentin, Lyrica, Cymbalta, all these things supposed to help out with nerve pain, right? And yes, but what if there was things that we could do, and I'll talk about some of the evidence behind that could help neuropathy. What is the underlying cause of neuropathy?
Nerve inflammation.
Nerve inflammation. What usually occurs of why is that nerve inflamed or not working correctly?
Like sugar, diabetes.
Right, which decreases what?
Blood.
Yes, blood flow. So decreased capillary flow to the nerve, right? What if you can increase capillary flow to the nerve? What should that help?
Neuropathy.
It should help neuropathy, right? Well, I'll just the answer, well, what does movement do? Increase blood flow. All right, great. So you see how some of these things are correlated that you don't necessarily think could be helpful, and there's other things that actually could help, and I'll talk about those, such as angiogenesis and other things that can actually are supported in the research that we can actually have at our disposal and therefore at your disposal if we're your partner in quarterbacking these patients. Okay? All right, so how many people do you think go to the ER per year for lower back pain?
Millions of people.
Yeah.
30%.
30% of people in general. So out of the 8 billion people there. Well, not far off. So let's just say America, 3 million people per year go to the ER for back pain. And then what do they go after the ER the next day? They go to y'all, right? Family medicine and PCP. So if you think about it, and that's why I knew about 80% of y'all who raised your hand went for lower back pain, because 80% of people will have some sort of episode of lower back pain in their life. How many times have you had a patient say, I have a disc injury, it's my old disc injury, right? When did that happen? And you're taking your great subjective history. 12 years ago, 20 years ago. Do you think that disc is still blown out after 20 years? What is a disc made out of? As everything else is. Yeah, but it's made out of collagen, right? Does collagen heal? Collagen heals. Collagen scars down. Do you think 20 years it probably might have scarred down? But you're also dealing with the nerve root that's right there, the facet joint that's right there, the multifidus muscle that's right there, all these other systems that haven't been addressed from the root cause or the initial injury 20 years ago. So I just want to kind of open up y'all's mind a little bit and how you're thinking about this, okay? All right, so if that many people go for lower back pain, if you think about, as a PCP, how many of those people that go to the ER and then come into, they go on the weekend and you get them on Monday morning, how many of those people do you think get sent to physical therapy? Just a percentage out of 100%. How many percentage of people who go to the ER and then find out or follow up with their PCP or family medicine go to physical therapy right off?
Referred or like physical?
Referred.
50%.
Yeah. Okay, anyone else?
20.
20? Okay.
2%? You're
Oh my
joking.
goodness.
2% of people get sent to physical therapy from some sort of primary physician.
I refer so many patients.
Right, well, that's what I'm saying. Y'all are the exception then, okay? But I'm just saying, nationally, 2% of people get referred to PT first. How many do you think in the first 90 days then? Because they probably came back, because what happens, you come in, you get your x-ray, so they come back after 4 weeks, you gave them their NSAIDs, the muscle relaxer. So how many people then, how many percentage go after 90 days?
10.
7. 93% of people then just get stuck in this bad negative feedback loop. Or they just say, oh, the medication helped a little bit, so I'm just going to ride it out. But basically, if they can get to PT within the first 14 days of initial lower back episode, I know I keep asking questions, but how much lower could medical costs be for that person's lower back pain, percentage-wise, if they saw PT within 14 days? Random, throw it out.
38%.
I love it, very specific. So you can decrease the cost of that episode of lower back pain, so meaning they would go to a specialist, they get an MRI, possibly an epidural steroid injection, maybe a, do what?
Oh, he said, I guess higher now.
Right, exactly. So you're thinking they get an MRI, they get an epidural, they might get a medial branch block, they might have to get ablation. Oh, well, guess what? None of it worked. Hey, let's go get a laminectomy, let's get a discectomy. Well, let's just fuse the thing. So you think all the downstream effects that can happen from someone being like, oh, my back hurts. I'm going to go see my PCP. Okay? You can decrease all of those medical costs by 60% by getting to PT in the first 14 days of an initial lower back episode. Do you think that gives y'all a lot of credence and a lot of support that you could do to refer to PT, right? And it also allows you to follow up with the patient. Who has sent a PT to a specialist and not heard, or sent a patient to a specialist and not heard back about them? Right. They get caught in their system then, right? It's a different EMR, we're not connected to them, they went to their PT or whatever it may be. You lose track of them a lot of times. And if y'all are the quarterback, you want to know where your patient is. We all got into this profession for one reason, to serve people, right? To be altruistic, we want to help people. So if you can use all of these things at your disposal, then why not help people, right? And so I'm just trying to open up your eyes a little bit on this, okay? So other things that you might see on here, any questions about this? Though, pelvic health and incontinence, I've been told, I come by knowing about physicians honestly. My dad's a physician, so that's probably why I'm not a physician. But in family health, y'all are learning about delivering babies and things like that, right? So what do most women who are pregnant complain about?
Shortness of breath.
D, all the above. But yes, I mean, and just to let you know, my father was an OBGYN, or is an OBGYN, still practicing. So with women who are pregnant, who have lower back pain, sciatica, they can be treated by physical therapy. It's not that we're going to go in and do manipulation on them because of the relaxin and other downstream effects from their hormone changes, but we can do other hands-on techniques in order to calm down that pain. I've seen women come in on walkers that they're in their third trimester, like, I can't make it another couple months. I can't. And we're able to do things that allow them to walk, and they have other kids at home, and you have all these things that they're trying to do, and they can't. Yes?
Sorry, this is for when
Please.
you're finished with the pregnancy.
Okay, sure.
I just had a question about the headaches.
Of course. So pregnancy. So during pregnancy, can still be seen by physical therapy. After pregnancy, have y'all heard of the term fourth trimester? Yeah. So fourth trimester is where PT is a great adjunct to be used. There's a lot more women's health physical therapy now than there ever was. When I first moved back here about 18 years ago, there wasn't a whole lot. I think there was 2. Now they're kind of all around. But know that that is part of it. Now, I was kind of one of the people spearheading that, because when I dealt with so much of chronic pelvic pain and postpartum lower back pain, I could get them like 80-90% improved, but then there was the incontinence, the pain with intercourse, the other things like that that needed internal work to be able to be released. So I don't think I did have that under-referred, but I don't believe it's under-referred now. But during pregnancy, I definitely think is under-referred because people are a little scared. They're pregnant. I don't want to mess anything up. But what we're doing is it's very gentle and would not mess up the pregnancy. Okay. Headaches. Yes, ma'am.
Yeah, so is it just for like tension type headaches where you have muscle tightening, or are you talking about like migraines? Are you talking about like other things as well?
Yes. Because, okay, there's lots of classifications of headaches. Has anyone studied or looked at some of the headache classifications? I think there's like maybe 20 classifications of headaches. I mean, cluster headaches, you have a true migraine, vasodilation, that's only seen on MRIs, tension headaches, stress headaches, cervicogenic headaches, you have sinus headaches. All these things are headaches. As a physical therapist, what we have time to do, not saying that y'all don't, but the majority of the time you don't have time to, is then able to differentially diagnose that. Is it actually coming from a musculoskeletal referral pattern? Is it coming from a thoracic issue, like a sympathetic nervous system issue? So even with a migraine, which we're not going to change the problem when someone has an aura and vasodilation of the brain, but usually, if I usually tell someone there's a tipping point where you get to the migraine, okay? But if you think of a bell curve, there's always that tail end, that beginning end, and in that first part, there's usually a you have migraines, don't you?
Yeah.
Okay. I was like, someone nodding like,
With
yes.
aura.
With an aura.
Both
And,
of us are strugglers.
yeah. Actually, I see the table back there. I brought a table in. If y'all do want to see anything, if I'm good on my time, I can show you all some of the techniques and things. Everyone's like, you brought a table, yeah. But yes, so all of those things can be helped, but there's that front tail before I think someone hits the tipping point to a migraine, that if you can know what your triggers are, be it food, be it stress, be it caffeine, you can then, one, limit the triggers, two, if you see where the cervicogenic headaches begin before the tipping point in the migraine, you can turn down the possible, you're like, well, maybe, yeah. You can turn down the intensity of the migraine and not be locked in the room for 48 hours with all your meclizine, all the other stuff that you gotta take. So yes, there's a lot of musculoskeletal components to all headaches. It's just a matter of what we can do and can we actually. I've had people come in who say they have migraines and they have headaches every day, and we treat them, they're like, wow, I've only had one migraine this week. I'm like, I don't think that's a true migraine. I think you had whatever we did, you had a cervicogenic headache, you had a sympathetic nervous system, aggravation to the head, you had a trigger point referral pattern to the head. All those things are what we get time to test out and differentially diagnose. Okay. And so the neuropathy. We'll get into some of the research behind it, but there's lots of good modalities as well as hands-on treatment techniques to increase blood flow to the periphery, okay, so to the feet and to the hands, which is normally where neuropathy occurs. But there's actually a cool device that we utilize, but there's other things that tout angiogenesis. But if you can regrow peripheral blood vessels, well, guess what? You just decrease neuropathy, which people don't think can actually be helped, right? It's one of those, gabapentin, Lyrica, that's what we got. That helps, but what if you could add something else that would help out the system that was problematic to begin with and caused the degeneration and the demyelination of that peripheral nerve, right? Okay. Any questions so far? You good? All right. So what happens during a physical therapy evaluation? Since all of y'all have been to the PT, most of you, so obviously we take a subjective interview, what y'all are learning, movement screening, functional testing, and I'll get into that a little bit more. And this is, I can really only testify to what we do, just because y'all can probably understand that if you've been through physical therapy, you're coming with like, oh, well, they didn't touch me at all, or they told me to go ride the bike, or they told me to go do this or do that. I have people all the time ask our therapists, why is it different that I came to see you? And I'm like, I don't know. This is the only way I've practiced. It's kind of like if you learn that and you just keep repeating that, and someone's like, well, why didn't the other doctor do that? I don't know. I don't know where they went to school. That's where it's not all created equal, unfortunately. So the hands-on assessment, joint, soft tissue, neural, so that's where we're using our hands. It could be joint manipulation, neural tension testing, soft tissue work, trigger point referral pattern testing, all of those things. And then we always educate starting day one and along with treatment as well. And then we also give them our plan of care with functional goals, because I came out of school not really knowing how we prescribe our physical therapy. It was just like, oh, you're coming for 3 times a week for 4 weeks. Well, there's reasoning behind that. It's kind of like the whole 3 sets of 10. Because who works out? Anyone? Yeah. Oh, well, how many sets and reps did you do? I did 3 sets of 10. And it's like, that's just now there is scientific basis behind that if you remember your exercise physiology, but it depends on what your goals are. Well, guess what? We need to build strength. Okay, well, we need to be more in that 5 to 8 category and maybe 3 to 4 sets. And so there's a reason that it's a norm, but it's not always a reason to continue doing that for that person. It's not a one size fits all. So hopefully I'm just opening up your eyes to that. Okay, so how we treat. So we use a 4-phase recovery model. And what that is the 4 phases are pain, prime, perform, and prevention. And this is what we show people. I can have someone very acute, or I can have someone come in that said, I had a disc injury 20 years ago. And I can tell them where they lie on the spectrum and probably why they're still having an issue. Okay? So pain, obviously we need to calm things down. That's where y'all get to come in and help us out. I'm like, hey, they gave me a dose pack, they gave me this, they gave me that. Good. That's going to help calm down. So I employ y'all. You give the dose pack. Don't say don't go to physical therapy, or you give them the NSAIDs, or you give them. I think I heard from another doc. The whole combination of the NSAID and the Tylenol together seem to kind of be a good combination. Like the 1 + 1 = 3 on those things. Is that yeah? Okay, so I'm not far off. I heard right. I'm listening to the right podcast then. So, but y'all get to do that to allow the flame to calm down, and then we can get in and figure out what that root cause is, that system that if it is a musculoskeletal thing that we have under our control or our ability to address. Okay, so that's where y'all get to come in. Priming, that's restoring alignment, control, and mobility. That's where we're really using our hands to affect the motion of the joint, the tension of the muscle, the neurology, all of those things. And I'll get into it a little bit. I might just go ahead and caveat or tell about now. So when we say manual therapy, I don't hang my hat on that as much as I did before. All we're doing, I hold everything that I do with an open hand, because doing this over 20 years, things change, right? If we're not evidence-based, I used to think that I could get in, and if anyone has anyone seen a chiropractor? Yeah? I used to, and no knocking chiropractors, I have some very good friends who are chiropractors. I used to think I could go in and I could move L5 on S1, and I'm manipulating C2 on C3, that I had that precision. Guess what? What's been shown in the research? How if I'm going in there, I'm moving probably 5 or 6 segments, okay? If I get a cavitation, I'm popping 4 or 5 different things, all right? So we are not very specific with our manual therapy. However, what does that give us? I then treated the neurological system that gives me a window of opportunity to then get that movement pattern to be more normalized. Does that make sense? And actually, after manipulation, when we do that, we reset the multifidus at neurological level, and it can last up to 7 days for that neurological level. So if someone actually does what I would call reinforcement, and we'll get into that, then they can help maintain the gains that they get from our hands-on treatment. So I love doing the stuff. I love doing manipulation. I love needling. I love doing all the hands-on stuff. But understanding that that's only a bridge to get them to move better and to then get stronger. Okay? All right, and then we go into the perform. That's when we then get to start strengthening them. That hits save on the document. So, and this goes into my next slide, but we'll get into resetting things, then we reinforce it, then we reload it. All right? And then the prevention, that's usually done outside of the clinic. That's where, hey, go to the gym, go do all the things you want to do. All the things that you didn't get to do because you're in here right now. All right? Good. So this tells you about the role of functional and restorative exercise. We retrain faulty neuromuscular patterns, reinforce manual therapy outcomes, helps prevent reoccurrence, and it empowers patients with sustained home programs. So that's what I was saying. We basically give the environment for things to be reinforced or reset, and then we retrain those neuromuscular patterns. Because if someone's come in with, oh, I've always had sciatica on this side, but now my left side hurts. Did they injure their left side? No, they've been compensating for so long on this side that then they started hurting on this side. Now, yes, there is the little recurrent nerve in the spine that does go to the other side, so yes, it spreads out. However, you're thinking, okay, there's compensating patterns. So if we can retrain these faulty neuromuscular patterns and then be able to reset it with the manual and reinforce it with the programs, the corrective exercise that we give at home, then we can actually strengthen it and build resiliency into that human, so then they don't have to come back and see you unless they have something else going on, and then you get them again, right? Okay, good. So the 3 R's to successful physical therapy. This is what I was discussing before. So reset, reinforce, reload. I kind of think I broke it down as a bad mechanical engineer. So what do you do with your computer when it's not working right? Restart it. Control Alt Delete. If you're Windows, I have a Windows or I have a Mac and I don't even know how to do the restart on it. I just hold the button down. But you reset it, okay? And if you keep resetting it, what happens? It starts running a little bit better, right? You clear out all the junk, right? Take out the trash. Bring in the good blood flow. Same thing with when we talked about the neuropathy stuff. Take out the trash, bring in good blood flow. That's what the body wants, okay? So that's what we get to do with our hands-on. We get the joint mobilization, soft tissue work, massage, needling, all the cupping, all the good stuff that people love to have done, but then they actually then need to put in the work, and that's where the reinforcement or the corrective exercise comes in. All right, so all the people who went to physical therapy, did you get a laundry list of exercises? Yes or yes? Right? So why do a laundry list of exercises? Because my guess is you didn't go to physical therapy just because you liked physical therapy. There was something wrong. You had some pain, you couldn't do something, there was something wrong. You had a headache, there's something wrong. If you're in pain and I gave you 10 different exercises, would you do them?
No.
I wouldn't do them. So where we talk about, it's become a buzzword in physical therapy, is this therapeutic alliance. And I don't know if y'all might have another term, this patient rapport when it comes down to it. If you don't understand that the person's not going to do what you ask them to do, why tell them to go do it, right? So that's where, for me, my reinforcement, I had 3 new people I saw this morning. They each got like 1, maybe 2 things to do. Why? Because they're telling me if I'm doing the right thing. It's just like, you take this medication, you take it as I prescribe it, and if you feel better, I know I was right on my diagnosis, right? So same thing for us. I did a movement assessment, I did a treatment, I retested it, they felt better. Guess what? Here's your reinforcement exercise to do this many times until you come back so that you can tell me if I'm on the right track or not. All right? And then we get to reload that, and that's hitting save on that document. That's uploading new software onto your computer to run it faster. Okay? All right. So what is manual therapy? We talked about that, and then the evidence-based modalities. So evidence-based manual therapy and exercise has been shown to be better than rest and just letting it be. Taking medications and resting. Manual therapy and exercise has been shown to be better than that. Now, not to the degree that we thought it was 20 years ago, but to the point that we're resetting that neurological system to allow the body to actually work more efficiently and effectively so that they can get back to the exercise. Neuromuscular re-education, teaching the muscle to do its job again because it's been in dysfunction or it's been problematic on one side for so long, okay? And then progressive resistive training, that's the reloading. And then the vestibular imbalance rehab. I mean, a lot of people don't realize that physical therapists are able to be in that realm too. We treat PPPV all the time and are able to figure out, is it the posterior canal 97% of the time, horizontal, anterior canal, be able to reset that. Then retrain the vestibular system so that if they have been dizzy for that long, then if they don't have a central issue and we can just deal with the peripheral issue, okay? Or if they're just, they have balance issues becoming older, they've been guarded. Well, guess what? They probably had an injury to begin with that then made them guard and then decreased their balance. So then you see all the downstream effects that if you all got them and used us as your ancillary service quickly, is you could prevent a whole downstream effect of what could happen to these people if they don't keep moving correctly. Yes?
Question, with vestibular PT, is there like a special PT for that, or pretty much any PT will also treat vestibular issues?
Yes. We graduate generalists,
Right.
and so we learn how to do the Epley maneuver, how to test Dix-Hall pike. We learn how to do VOR. We learn all that stuff. Now then, just like y'all go into residency for
Right.
family medicine, and someone else goes for ortho, you might forget about how to do your ortho exam,
Mm-hmm.
okay? In 20 years, not right now, you better remember right now. But a lot of times an outpatient physical therapist should be able to treat vestibular type of treatment. So like today, I had a patient who came in for dizziness. She had a positive Dix-Hallpike. I treated with an epilepsy maneuver. This was a month ago, but she still was dizzy. And so then we were treating cervicogenic dizziness, where we had to get in, loosen up cervical facet joints, and she also had some trouble with hoarseness, and she couldn't get rid of that. So we were doing soft tissue work along the anterior part of the neck. So all those things, it's usually not just vestibular. So that's where if someone can go in and be able to treat that and then see what the other systems are involved with that, then you're able to then see the person as a whole and not just a diagnosis.
Okay.
Because that's the other thing that I have an issue is like, oh, you go to a bigger place like what's your name?
Sophie.
Sophie's over there with the dizzy issue, but we don't know about, oh, well, I had an issue with my upper back, and so therefore I didn't move, and so if I didn't move my upper back, I don't want to move my head, and then I got the vestibular issue because I locked down my neck, okay? So it's understanding the downstream effect for things, and the person is not their diagnosis, they're that cumulative effect of how they got there to begin with. And that's what we get to do as supporting service for y'all, is be able to treat all those things for you. And then be able to report back from you. Hopefully y'all are if you do send out to physical therapy, hopefully y'all are getting our reports back in a timely manner, which we should be doing within 48 hours of our evaluation. And then when you look at the evidence on modalities, ultrasound has been refuted in the evidence as far as therapeutic ultrasound, not obviously for diagnostics. Now we are getting into, a lot of physical therapists are getting into use of diagnostic ultrasound to then show movement assessment. Is there true impingement? Is there a rotator cuff tear? That's something that's coming about. I use it for tendon needling, so I know that I'm in a certain tendon when I'm needling at a plantar fascial, periosteal, pecking, those sorts of things. TENS unit, it is research, but knowing that is only surface level relief. So if anyone runs in the side of the door, what do? What are you turning on? You're turning on those fibers that are faster than the nerve fibers and using that gate control theory of pain. There are other modalities. There is something that I've found called the H-wave. It doesn't stand for anything. I think it's the guy's name, but that has been shown to actually turn off the sodium pump of the nerve to get longer lasting effects of pain relief. It was actually came out in the 80s to be used as dental anesthesia in someone who can't go under general. Okay, so there are evidence-based modalities that can help. That's also the machine that has been shown in research and models more in the veteran side of things to help create angiogenesis, or that regrowth of blood vessels to the peripheral nervous system. Kinesiotaping, it hasn't been shown to do what it says it does. Like it said, if y'all had taping done, it opens up the lymphatic vessels and moves things around. I just believe it's a tactile cueing. I'm also, as people like to say, I have the alphabet soup after my name, which I don't even care about anymore, but I'm an old athletic trainer too. I would tape anything. But the thing is, I'm giving you a tactile cue or a kinesthetic activation to then go do whatever you want to be able to do. Okay? So again, holding everything with an open hand. All right, and then shockwave, if you've heard of that, that's kind of a new craze now. But there's some good research that basically refutes that, what it's doing as well, going in and breaking something up. It's what I think it came out of the use of I don't know, y'all would know the word, but the breaking up of the kidney stones, whatever.
Lithotripsy.
Yes, yes. So that's what it came out of, was using that, like, well, let's break up actually scar tissue that's formed from a tendinopathy or something like that. Okay? But knowing that has lower evidence in that regards. Okay? All right, so just go through what these are. So occupational therapy, they deal more with fine motor skills, activities of daily living, upper extremity coordination, and cognition. They've actually transitioned into a little bit more cognitive therapists as well, depending on what sort of schooling or what sort of school they're at, okay? My wife is also a physical therapist, and in a hospital she always got, because they would split them up and basically say, oh, OT gets upper body and PT gets lower body, yet they didn't know those systems as well, but they do work a lot with the fine ADLs and how to dress, don, and doff, that sort of thing. Chiropractic treatment, spinal manipulation, alignment, acute relief. To juxtapose what I told you, yes, I do manipulation. It just depends on what state in, is if I could say spinal manipulation or just joint manipulation, or if I need to say joint mobilization grade 5 with a cavitation. All the same thing. It's just dependent on the state's practice act. But we are trained in that type of treatment as well. Our philosophy is the difference, because some of y'all have been to chiropractor. Have you been to PT as well? Has the PT done manual therapy on you?
Tens.
Tens, okay, right. Exactly. Why? Because the evidence is low on it, right? So a lot of people come to me like, oh, well, what's the difference between you and a chiropractor? I'm like, well, they have DC after their name and I have DPT after my name, and that's the difference. But a lot of the educational residencies that I've been through, I'm taught by chiropractors, and they said if you go into a good chiropractor's office or a good PT office, you shouldn't really see a difference. There's something called rehab chiropractors now, and they're kind of, again, having their foot in both camps, just kind of like I am as a manual therapist. But it's the philosophy. Most people who go to chiropractors, and I'm making a generalization because the majority of people are in this realm, is they're a maintenance profession. So I'm going to do my manipulation, you're going to feel better, you're going to see me 3 times a week, you're going to see me 2 times a week after that, you're going to see me once a week for the rest of your life, and you're going to pay me now. Right? And for us, I usually tell someone, I like you, I don't like you that much. I want to reset it, give you the things to do that you need to do, and then teach you how not to come back and see me. I want to teach you how to fish, okay? So that's really the difference. And there's definitely a big philosophy. There's something called the law of the nerve and the law of the artery, where you have probably heard of some chiropractors thinking that they can cure heart disease and get rid of indigestion through spinal manipulation. And yes, there is correlation to those nerves, and there is the gut-brain axis and all that. But just through pure spinal manipulation, I'm a little hesitant about, or if they're saying that they're curing something through spinal manipulation. Again, all of my manual I keep with an open hand. I am resetting you on a neurological basis so I can get you to move better, and then we can strengthen that system and make you more resilient. Okay? All right, personal training. So fitness and strength focused, not a medical or insurance-based modality, but plays a big role in what we do. I will refer on to personal training, especially in that older population who I know need to strength train, yet don't really want to, and haven't done it before. So it's a good low barrier to get them going. All right, and then physical therapy, gross motor rehab, gait, pain, strength, manual therapy. And then we've talked about all the types of manual therapy. Was there any questions on that at all, specifically? Massage therapy could be in there as well. Again, that's dealing with one of the systems. And I tell people I came out as a manual therapist, and that's what I did my training in afterwards. But I'm almost working more as a neurological therapist now because of knowing how much that system is. I mean, what do you think causes pain? Right? The brain decides if there's pain. This just gives a sensation, and then my brain just decided is that painful or not? And everyone's different. So that's why you have to figure out how is their sensitivity to their neurological system. Can they actually tolerate the type of manual therapy that I'm doing, or do I need to regress or progress in that regards? Okay? All right. So these are just some things we can talk about if you want. I've already thrown out a little bit as far as scenarios, chronic lower back pain, unresponsive medication. But if you send them physical therapy, it could be resolved through core integration and manual therapy resets. Fall risk for the elderly, we've talked about vestibular. So vestibular PT reduced the fall anxiety, so that's the habituation, so it was more of a central issue versus a peripheral issue, the BPPV, and they needed habituation exercises and actually strengthening. Because with strength, decreases falls, okay? Postpartum case, pelvic health led to restoration of continence and return to activity. I think that's in conjunction with looking at the hips and lower back and that sort of thing. And then I also put this in because y'all are probably seeing a lot of this. Y'all see a lot of chronic disease, right? I mean, diabetes, heart disease, all of these things. What is the one thing that can help every single one of the chronic diseases?
Healthy lifestyle,
Movement.
Exercise, movement, lifestyle changes. That is the longevity X factor. But do people want to do it? No, because it's work. It's work. And that's hopefully where we can come in and actually help support that and saying, hey, your doctor talked about this. This is where the research lies, and we can have, because we will be able to get them on a 2 to 3 day week timeline and be able to impart that relational equity so that then we can actually get them to hopefully make a lifestyle change. But the great things are, all the GLP-1s and all those things, you have your ability to make a huge difference. However, I'm also going to give a little plug. Every person that y'all give a GLP-1 to needs to go to physical therapy. Because if they don't put muscle in their body, you can tell who's on Ozempic across the room if they don't exercise, right? It is starting to break down muscle. You see it, yeah. You know the face, you know the way they look, but they have to prioritize protein and they have to prioritize strength training. All right? So every one of those people is definitely a candidate for a physical therapy referral. Saying, this is a chronic disease state, I've done this, I'm following up this amount, I need you to do this. Tell us what you want. We're here to support you. That's what we're in school. We are the ancillary service to the medical community. Yes, we're allied medical professional, but we're y'all's support system. Okay? Well, I gotta land the plane. Okay. So when to refer and what to expect. So early referral limits, overuse of imaging and pharma. We talked about that. You save 60% down the road as far as lower back pain, regular updates, foster collaboration. Hopefully y'all are getting those from our industry. And we recognize treating root mechanics, not just easing symptoms. So that's the symptoms versus the system model. All right, questions? So just out of curiosity, what challenges do y'all face with referring to musculoskeletal or referring musculoskeletal patient? Oh, there we go. All right. I'll take you first.
Most of the time when patients come to their doctors, they just want a quick fix,
Correct.
medication, just fix this now. I don't have 6 weeks or 8 weeks or however long it takes to go through therapy.
And that's the thing, is that you can do that, yet say, and y'all come with such an incredible, you don't realize how much power y'all hold. Y'all come with authority. Why? Because you're their doctor. It doesn't matter that I'm a doctor of physical therapy. It doesn't matter to them, okay? But if y'all say, look, I'm going to give this to you to help your pain. You have a issue in this system, and that's what physical therapy will do. And then all you can do is give them as much information as you can to help them make a better decision, right? The problem is all y'all have been through physical therapy, and you're sitting there because I know you want me to work on your neck. Well,
I've been migraine free for a year.
awesome.
I wish I could be there.
So with that said, they have a bad taste in their mouth probably from physical therapy. And that's when you have to, that's where hopefully collaboratively, and that's why I love why Dr. Busby allowed me to come in and speak to y'all, is you might ask around for a physical therapist. And if you send someone there like, hey, I want you to go test this person out for me. Tell me if they're any good. Did they put their hand? I have family all over the country, and they're like, well, who should I go see? Pick a physical therapist, call them up, and ask the front desk, do y'all do one-on-one, because you want them to be able to not have 4 people around them, because who's been to an orthopedic physical therapist? Are there 2 or 3 people all with the same therapist? Yes, most of the time, or you get sent off to the PTA. Do you do one-on-one, hands-on physical therapy? If the front desk doesn't know that, I click and call the next person. So that's what you can do, is do that wherever you start your practice, is find that go-to person who you can trust, or that go-to practice who you can trust, okay? And then you can hopefully say, hey, Ms. Smith, I'm giving you this. I don't know these people, but I want you to test them for me. And then actually you're gonna come back in 2 weeks and tell me if they worked. And guess what? They will do for you. They'll go do that. And then you can know, like, what did they do? Well, they had me lying down and doing straight leg raises and my knee rock side to side, and like, did they put their hands on you or loosen up a muscle or anything? Okay, good. Well, here's another place. Go test this place out for me. Then you can actually get it from, the horse's mouth, so to speak. Okay? So go.
I feel like I get a lot of like, oh, I tried physical therapy before, and they tried it, it just made me hurt more, and it didn't, like, they'll just say, like, I think it said it was like making their issues
Making it worse.
Yeah.
And that happens sometimes because they were so deconditioned
Yeah.
to begin with.
Yeah.
And that's where your education comes in, and the problem is that the PT probably didn't educate them in that as well. Because I usually will say, hey, this might make you sore, we got you moving better. But that's that's why our model is test, treat, retest. The person sees the buy-in, then they're actually gonna then do it, and then they'll understand why they might be able to sore. Oh, well, I can still touch my toes and I can only touch my thighs before. Well, that's why you're sore, because you haven't touched your toes in 5 years.
Yeah.
There's a lot of tissue there, a lot of neurology that's pissed off and needed to be worked on. And there's other ways that we can calm that down using other different modalities and other things to help calm that down. Okay? Does that answer your question?
Yes.
Really, those were the 2 I was thinking of.
Yeah.
But then also just other random things would be the amount of times that patients have to go. I've heard that complaint of saying, I don't want to go 2-3 times a week. I just want to go at once.
So,
and transportation for our patient population.
right. Transportation's tough, because I've talked to a couple of people here. It's like, all right, that's tough. Now, when they want a one-off fix, that's not going to be the issue, even if they go to a chiropractor, because you have to say, well, how long did it take you to get here? It's not going to take you 1 visit to get there. And then for me, if you think about that reset, reinforce, reload model, one is you saw that on our 4 phases of rehab. I don't know if I'll be able to get back to it, but this is how we do our kind of a custom plan of care. Is like, where are they? Are they in the inflammatory phase? Usually I can calm something down in that first 8 visits or so, but you have to think all the systems that are involved there. Am I dealing just with just a muscle, just a nerve, just a joint? No, I'm dealing with all of them. And then it's like, what do they actually want to get back to doing? And if you think about what's the tissue adaptation for strength training? How do you know how long does it take for someone to get stronger? 6 to 8 weeks, okay? So that's where it's like, yeah, you might see them more often at the beginning, and then we're gonna tailor off in order to then reach to those more specific functional goals and strengthening to hit save on that document. So again, it's a lot of education on, and I know y'all don't get a lot of time with your patients. I hate that, and that's probably why I didn't go into the medical side of things. But just being able to say that, I know you can't go there that often. And if you can only go once a week, guess what? It's just gonna take a little longer. Doesn't mean it's not gonna work. It just means that you might need to do a lot more reinforcement at home. And we actually have an app that people can, text us and email us through between sessions, because then that allows them a little bit more data points to figure out how they are getting better. Okay? transportation's a big thing, and then, because usually then that's someone on the Blue Care or, 10 Care type thing. And unfortunately, I've been in that realm as well, and the compliance there is just not good anyway. So you kind of do what you can. Yeah. Anything else? Let's see if I actually got through everything.
Is there anything that primary care doctors do that you wish, from as a physical therapist perspective, you'd be like, stop doing this, or
That,
do that?
from my standpoint?
Yeah.
I've never been asked that.
Okay.
Awesome. So what, from a physical therapy standpoint, could primary care physicians do better or do?
Yes.
My big thing is understanding the power y'all have. Because if you say, go to physical therapy, and you believe that it will help, your conviction in telling them that will get them to go. Okay? Understand the power you have. Because you are in a very unique situation in primary care and family medicine because you get to see them first. You get to then quarterback it, and hopefully then you create, like what over the 20 years I've been doing, you create these people that, oh, I'm only going to send over here because I know that they're going to be a person, not just a patient to them. And that's one of our core values. They're a person first and a patient second, because y'all get to know them. You see them every year when they come around. Okay. Okay. And how can we simplify it? Okay. So that's the other thing is is just the referral process. Is if you think it's a musculoskeletal injury, it's at least worth a physical therapy referral. And you'll know if they don't go. Because if we get a referral and we don't get it, and we don't get them in within a week, I'm then saying, hey, Miss Smith, Sophie? Dr. Sophie told you to come see us for some plantar fasciitis, and we haven't seen you. We're going to let her know that you didn't come in. Because then what are they going to come back in 2 weeks and say to you?
It's still hurting.
It's still hurting. And that's when you do the
And then
proverbial.
yeah,
Did you go to
I went
therapy?
I went to 3 sessions of PT and they went to not one. Yeah, I've been to PT.
And that's when you're like, well, Trevor, the PT over here, told me that you didn't show up. Like, oh, I went to somewhere else. Well, I really wanted you to go over here because I know that you'll be treated this way. And that's what y'all are going to have to do wherever you decide to land with your practice, is hopefully develop that. Now, and again, I'm not trying to paint a bad light on us as physical therapists, but as we talked about, just as primary care docs aren't all created equal, neither are physical therapists. Okay? Anything else? Thank y'all so much for your time. I appreciate it. I'm more than willing to answer questions afterwards if y'all have any. It's 5 o'clock. It's time to go home.